Two internationally recognized researchers, Dr. Jan Leefman and Chandler Park. Our chairs include Dr. Park and Dr. Leefman. Our associate directors include Madhuri Balasubramanian, Muskan Joshi, and Gayatri Menon. Our associate managers include Alexandra, William Wilkerson, Pallavi Pai, and Ahmed. Our educational committee includes Sean, Shubha Power, Harshal Chopra, Rida, Shri Soumya Nadar, Rabab Imad, and me. We also would like to thank our partners, Vimedi and National Society of High School Scholars. The moderator for today's event is Madhuri Balasubramanian. And now, to introduce our keynote speaker, Dr. Matthew Matasar. Dr. Matthew Matasar is an internationally recognized leader, physician, and a researcher in hematology and oncology. He's a globally recognized leader who has led more than 30 clinical trials and has had FDA drug approvals. He's a recipient of multiple national awards, including the Hematology Attending Teaching Award. He's a passionate educator, having trained more than 50 trainees in all stages of training, with recognition for mentorship, excellence in multi-time Hematology Attending Teaching Award. He has authored more than 100 peer-reviewed publications, abstracts, and book chapters in internationally renowned journals, including the Journal of Clinical Oncology, Blood Cancer Journal, and the Journal of American Heart Association. With that, it is my pleasure to welcome Dr. Matthew. The floor is yours, Doctor.
Thank you so much. I will never like hearing myself introduced. I would much prefer, this is Dr. Matt Matasar. He's a lymphoma guy. He has some stuff to share with you. But thank you for the kind words and kind introduction. So, and thank you for, most importantly, for the invitation to speak with the audience this evening. It's really a tremendous honor. I'm deeply committed to the mission of education, as you may have gotten a sense from the introduction, and I really believe in the need and the good of globalization of our knowledge. It's always interesting to speak to global audiences about these subjects because these are not local problems; these are global problems. That being said, it's interesting to present from an American perspective because there are dramatic differences, not just in terms of epidemiology of illnesses like diffuse large B-cell lymphoma, but also in terms of access to care and different local and regional perspectives on care that are driven in part by differences in healthcare economics and healthcare policy. So it's always interesting to have a dialogue around these things. And one of the really best parts of my work is getting a chance to travel and interact with experts around the world and share perspectives. So in that light, it's my pleasure to be with you here this evening. It's a relatively short time we have this evening, so I chose to focus not just on the entirety of aggressive B-cell lymphoma or diffuse large B-cell lymphoma alone, but just to focus on the diagnostics and care of patients with newly diagnosed large cell lymphoma, so we could try to go deep instead of trying to go broad. Here are my disclosures. Always important to show your disclosures. So what will I try to do during our time together this evening? I'll try to give an overview of the diffuse large B-cell lymphoma landscape, talk a little bit about the results of and impact of an important clinical trial called the POLARIX trial, which was an evaluation of incorporating the antibody drug conjugate polatuzumab vedotin into the treatment of patients with newly diagnosed diffuse large B-cell lymphoma. And then I'll end just with a little bit of a preview of work that we are working on trying to move the field forward further. Always helpful just to frame these discussions with a case because this is about patients and not about just the science. So here's an example of a patient, 46-year-old man, presents without a history of comorbid illnesses. His presentation was such that he noticed painless groin adenopathy, along with the relatively prompt onset of fatigue. He presented to medical attention, underwent body imaging that revealed diffuse adenopathy, as well as bilateral renal masses and a liver mass. He went to get an FDG PET scan, which demonstrated that these findings were homogeneously and quite highly FDG avid. Blood tests were performed, including a markedly elevated LDH. He was appropriately referred for a surgical biopsy of one of his peripheral lymph nodes, and that biopsy revealed a diagnosis of non-germinal center diffuse large B-cell lymphoma with a typical immunophenotype for that illness, expressing CD20, which is a marker of B-cellness. CD10 was not expressed, that's a marker of germinal center nature. MUM1 was expressed, that's an activated B-cell marker. And genetic testing, FISH testing, was negative for translocation of the MYC gene. So the question posed to me and thus to you this evening is, how should such a patient be treated? So to take a step back, let's talk a little bit about diffuse large B-cell lymphoma. I know this is a varied audience, and I apologize if I take some things for granted, but just to make sure that we're all on the same page, diffuse large B-cell lymphoma is the prototypical aggressive B-cell lymphoma. In the United States, it makes up about a quarter of all new diagnoses of lymphoma, making it the most common type of lymphoma in America. And we know that diffuse large B-cell lymphoma is not one disease, but rather should be thought of as a number of different biological subtypes that all get treated under this rubric, under this umbrella of diffuse large B-cell lymphoma. And historically, we've subdivided diffuse large B-cell lymphoma by what's called the cell of origin, dividing it into these three relatively crude categories of activated B-cell, like germinal center diffuse large B-cell lymphoma, and then primary mediastinal lymphoma as a separate entity. PMBL, or primary mediastinal lymphoma, really has genetically a lot of overlap both between regular diffuse large B-cell lymphoma and Hodgkin lymphoma. It is really quite a different illness. But we've long known that at least prognostically for patients with newly diagnosed large cell lymphoma, the cell of origin does have an impact, with activated B-cell phenotype conferring an inferior prognosis as compared to germinal center large cell lymphoma, both in terms of progression-free survival as well as overall survival. And this has been seen consistently in the literature, both before rituximab became available and after. It's probably fair to say at this point that we know that this classification is really crude and lacks nuance, and we can do better. And there's a number of different ways that you can classify diffuse B-cell lymphoma more elegantly by individual biological subtypes. And the LymphGen classification is perhaps more popular right now, where you see that we are able to divide it into 6 biological categories that distribute it unevenly among the GCB, ABC, and unclassifiable subsets. You can also do cluster analysis. And really, as we move away from classification towards individual genetic lesions that we understand are represented in and drive the underlying disease biology by the subsets, this is where the field is going to take us as we think about increasingly targeted approaches to this and other forms of lymphoma. Unfortunately, we have a lot of sophistication around the biological subsetting of patients. That doesn't always translate, at least historically, to differences in our therapeutic approach to patients with newly diagnosed diffuse large B-cell lymphoma, because at least, up until last year, kind of all roads led to Rome. And if you had the ability to receive it and were an appropriate candidate for such treatment, usually you were getting treated with R-CHOP chemoimmunotherapy with minor exceptions to that. So how do we think a little bit beyond the one-size-fits-all approach? It's worth pointing out, of course, that when we talk about R-CHOP chemotherapy for 6 cycles, which is the historical standard, we know that there's patients who may have other approaches, and we know now quite well that patients with early stage, limited stage diffuse B-cell lymphoma don't necessarily need such extensive therapy. And very nice work done previously, including by my friend Dan Persky, has demonstrated quite clearly that 4 cycles of chemoimmunotherapy with R-CHOP is certainly appropriate and sufficient for many patients with early stage large cell lymphoma. This was shown very clearly as well in what's called the FLIER trial, which randomized patients who were younger, had early stage, low International Prognostic Index, age-adjusted score, and did not have bulky disease, and randomized them to what was then the standard of care of 6 cycles of R-CHOP or 4 cycles of R-CHOP with 2 extra doses of rituximab. Editorial note, nobody ever gives the extra 2 doses of rituximab in real life, but this was done to satisfy regulatory considerations. And what we learned from FLIER is that very clearly for these low-risk early-stage patients, there is really no demonstrable benefit to speak of by pushing into that 5th and 6th cycle of R-CHOP chemotherapy. You could say, well, who cares? It's only 2 more cycles of chemo. That's not a big deal. Easy for you to say, you're not the one getting it. And we also know from very nice work done by my friend Talia Salt and others demonstrating that that incremental 2 cycles of R-CHOP chemotherapy, which carries with it 100 milligrams per square of doxorubicin, does increase your lifetime risk of cardiac complications, including congestive heart failure and cardiac morbidity and even mortality. So less is more. And if you can get away with 4, give 4. Other areas where the R-CHOP 6 one-size-fits-all approach hasn't been so obvious or so relevant, so true, is in care of patients who are older. We know that older patients have very different tolerance of full-dose R-CHOP chemotherapy. And historically, we've, as a country, the United States, been very heterogeneous in our approach to the care of patients over the age of 80, in particular, with diffuse large B-cell lymphoma. Historically, some have said, well, we know that they can't get full-dose R-CHOP chemotherapy, so let's go light. Let's not treat, or let's give chemotherapy without anthracycline in the form of CVP. And it's very clear that when you look at patients who are undertreated for their diffuse large B-cell lymphoma over the age of 80, that they really do have a worse prognosis. You could say, well, that's historical data. Maybe there's some confounding there. Maybe those patients are being treated so lightly because their comorbidities are forcing the oncologist not to give definitive treatment. But even when you do the best that you can with multivariate analysis, the only thing that emerges in terms of prognostic favorable for older patients being treated for large cell lymphoma is being treated with R-CHOP-like therapy. It reminds us, of course, that when we approach patients with an aggressive B-cell lymphoma, we always have to apply basic principles, which is that approach a patient as if they are curable until you know they are not curable. And if the disease is curable, and diffuse large B-cell lymphoma is definitely a curable illness by definition, we have to do our best to maximize the chances of cure while at the same time minimizing short and long-term risks. So how do we go about that minimizing risks? One way that we can do this is by attenuating the dosages of R-CHOP chemotherapy, administering what is colloquially known as mini-CHOP. Now, mini-CHOP, as you see in the box here, is a lowering of standard dosages, cyclophosphamide from 750 to 400, doxorubicin from 50 to 25, and so on. This is not, in truth, an underdosing of patients, and very nice work that has been done previously has shown that the actual tissue exposure in older patients when you use these attenuated doses is actually equivalent in terms of calculating the actual biological area under the curve for these drugs because of the changes in metabolism that are associated with aging processes, such that giving these doses is really physiologically delivering appropriate and full dose therapy. And when you give mini-CHOP to patients who are over the age of 80, we see that outcomes are not absolutely terrible, with a 2-year overall survival of 60%, a 2-year PFS of 47%. This is a starting point for this patient population. What else can we do when we think about how to take care of older patients? We know that not everybody over the age of 80 is created equally. We know that age is a very poor marker for fitness or frailty. And when you look at older patients and you divide them on a basis of a simple geriatric assessment, this is not a half an hour rigorous academic evaluation. This is very quick and practical clinic evaluation, that you can stratify patients prognostically quite stunningly into high, medium, and low risk, simply on the basis of frailty, reminding us that we really have to look at our older patients, not just at their driver's license, but actually look at the patient in clinic review. What else can we do to make treatment for older patients easier? It is very important to remember that the concept of pre-phase chemotherapy is fundamental to care of older patients with aggressive lymphoma. Pre-phase is a way of saying to give a little bit of light treatment immediately prior to the first cycle of true induction chemotherapy. And different styles of pre-phase exist. Some people do prednisone alone. Some people do prednisone and a single milligram fluoxetine. People in more resource available environments may choose to do prednisone plus a dose of rituximab. Be that as it may, it's something light in an attempt to do a little bit of disease debulking, try to address some of the underlying disease-related symptoms and improve performance status. And by doing this immediately prior to, like a week or 10 days prior to starting the first cycle of chemotherapy, you can improve performance status, you can improve drug tolerance, and you can actually measurably improve treatment-related mortality. We often tell our patients, well, in the broadest of senses, there's a cumulative nature to chemotherapy, that the last few cycles are the worst because it adds up. But we must also remember that the treatment-related mortality in older patients is highest with that first cycle, because patients are sick from their disease. This is a new treatment and a stress to their system. So we can see that cycle 1 treatment-related mortality is visibly reduced when you're able to successfully institute a pre-phase chemotherapy program. Mini-CHOP is a standard of care for the treatment of older or frail patients. It's certainly not the only one. And one of the limitations of mini-CHOP, of course, is that it still has H, it still has doxorubicin, which can still confer some measure of cardiac risk. And certainly we know that other cardiac comorbidities are more common as we age, and seeing moderate to severe cardiac dysfunction in older patients with large cell lymphoma certainly happens. And such patients would not be eligible even for dose attenuated doxorubicin, and they need other approaches. And shown here are some considerations that might be used for patients with impaired or frankly poor cardiac function. The one I list first is the one that I recommend most typically for older patients in my clinic, which is the RGCVP regimen. But really, when you look at the data underlying each of these approaches, it's not absolutely clear, allowing for the differences of cross-trial comparison and the like, that any one is better than any of the other. The top 3 are completely devoid of anthracycline in any formulation, whether infusional or liposomal or pegylated, what have you. Other areas of controversy, even in the R-CHOP is the only answer period, is this question of prophylaxis against relapse within the central nervous system. This really remains an area of unmet need and of uncertainty in my field. We've known for a long time now how to predict who's at risk for a recurrence of their aggressive B-cell lymphoma within the central nervous system, either the leptomeninges or parenchymal relapse. We know that the IPI risk factors are associated. We know that there are certain tissues that, when involved, confer increased risk, most notably the kidneys or adrenal glands, although testis, breast, paranasal sinuses, epidural disease all confer risk as well, most likely. And when you combine those IPI factors with geographic involvement of the disease, you can stratify patients into low, medium, and high risk, where the high risk group has approximately 15% risk of central nervous system relapse, so quite substantial risk. We can go beyond that system by incorporating disease biology and returning to that cell of origin construct of germinal center activated B cell that I introduced earlier in this presentation. We know that activated B cell phenotype disease is more prone to subsequent central nervous system relapse than is standard germinal center diffuse B cell lymphoma. And when you look at both that CNS IPI score from the prior slide and you combine it with cell of origin information, you can arrive at an even more robust prognostic model, whereas you can really identify patients who are at low or rather low risk and identify that subset of patients who are at that 15% heightened risk. So one thing to prognosticate is another thing altogether to do anything about it. We've known for a while that intrathecal methotrexate is, while historically a standard approach in some settings and remains an appropriate treatment in diseases like Burkitt lymphoma or even high-grade lymphoma that are at risk for early leptomeningeal progression. When you're talking about late relapse, it's most often parenchymal. So we've often turned to high-dose methotrexate as our preferred approach on a practical basis. We do so admitting, and I admit to you here tonight, that the data underlying this practice is at best mixed. And there was a large multi-center retrospective analysis that was reported out looking at patients with diffuse B-cell lymphoma treated with R-CHOP-like treatment all of whom had a CNS-IPI score of 4 or greater, that 15% risk group, and looked at the patients who were offered high-dose methotrexate as prophylaxis and those that weren't. And it turned out that the risk of relapse was about the same in both groups. So what does that mean? Well, it depends on if you're a glass half empty or glass half full kind of doc. If you're an optimist, you say the docs must have known who's at risk. They must have been able to sense it with their spidey sense. So the fact that the group that got high-dose methotrexate was no higher than the group that did not get it tells you that we were able to successfully reduce risk. That group should have been 15% and it was only 8%. That's wonderful. Or you could say, doctors don't have spidey sense. This is just the luck of the draw in terms of doctors having preferences. And the groups really don't look any different. This is the challenge with retrospective data, is that there's unmeasured confounding, that there's really no way to definitively answer such questions with such analyses. All we can say is that there's no definitive proof that it does work at reducing the risk, and yet there's no proof yet that it doesn't. So we leave it to individual docs and individual patients to talk about the pros and the cons and make a choice that everyone's comfortable with. We're all keenly interested in trying to move past the "we don't know, so give it your best guess" approach to medicine, which is not very satisfying, either as a clinician or as a patient, certainly not as a researcher. And we're trying to move into an era where we can be a little bit more discriminating. And there's a lot of tools that are becoming available to us, at least in research capacities, that could be brought to bear to this question, including work to identify cell-free DNA in the CSF. So you could imagine doing a diagnostic lumbar puncture, looking for cell-free DNA as a way to biologically risk stratify patients. There's very nice work that is prognostically very powerful. Whether we can use that type of insight and data to guide interventions, and whether we have any interventions that could successfully reduce risk, remain very important questions and priorities in the field. So for the longest time, yes, older patients, we have attenuated programs, we have questions of central nervous system prophylaxis, but by and large, for the majority of patients, up until the most recent of days, whatever the question, the answer was R-CHOP. So the question is, can we beat it? And historically, the answer has been nope. There's been lots of attempts at doing so, including trying to increase the intensity or the density of treatment, give it every 2 weeks, then every 3, give it infusional, give people a transplant afterwards to consolidate response, what have you. Those have not been successful, at least in randomized trials. They've all failed, with very minor exceptions. We can try giving maintenance treatment after patients are in remission to try to improve the cure rate. Those have failed to improve overall survival. We've tried incorporating other newer treatments like antibodies or antibody drug conjugates or small molecules. And here we're starting to have the first signs of progress. So intensified regimens, as I've suggested, have not moved the needle as much as we'd like. Has there been some signal that there may be progress with intensification in some situations? Yes. There's a program, instead of giving 6 cycles of R-CHOP, stopping after 4 and changing to a different chemotherapy regimen called ICE. And when you take this 1-2 punch approach, at least in a single arm phase 2 study, it looks like outcomes are better than would have been expected. There's a very famous randomized trial that was conducted in Europe comparing the RACVP regimen to R-CHOP 21, and it did show an improvement in a very small subset of patients. There was only age-adjusted IPI of equal to 1, and of course, Vindesine, which is the V in that program, isn't even available in America. So while it was a positive trial, it hasn't actually impacted treatment very broadly. These 2 programs of R-CHOP ICE and RACVP are actually quite similar. Yes, it's a different vinca. Bleo is in one, not the other, but they both have similar concepts of trying to use multiple agents that are non-cross resistant to try to come up with a chemotherapy program that may be more comprehensive. So what else has been tried? And here we have an important study which looked at the incorporation of bortezomib into newly diagnosed diffuse large B-cell lymphoma therapy. The study is called REMODEL-B. And this was a randomized trial taking patients who were either activated B-cell or high-grade lymphomas and randomized them to either get R-CHOP plus bortezomib or R-CHOP alone. This study, when it was first read out, was negative. Like all the other studies, there was really no difference in overall survival by arm at its first reporting. Importantly, this classification of patients was done on a more crude immunohistochemical approach. And when the investigators in Remodel B went back and looked not by immunohistochemistry, but by molecular classification, we get a different story. And this was reported at ASH this past year, where the molecular activated B cell patients in this trial actually did have an overall survival benefit post hoc compared to the ABC patients who were treated with R-CHOP alone. Similarly, although a very small number of patients, the molecular high-grade patients that were contained within the Remodel B patient population also experienced an improvement in overall survival compared to R-CHOP. Perhaps less relevant, R-CHOP is not our most favoritist program for high-grade lymphomas, but the ABC findings in particular are very provocative, as this is the first time that we've seen improvements in overall survival in a subset of patients, post hoc though it may be, and it certainly merits further follow-up. The conclusion of the Remodel B post hoc secondary analysis was that you can derive an improvement in overall survival with the incorporation of bortezomib into newly diagnosed patients when you're choosing your patients on the basis of gene expression profiling as opposed to immunohistochemistry. So are we seeing an evolution of standards? For the longest time, other than the advent of R-CHOP now over 2 decades ago, there's really been no substantive progress in the field up until maybe Remodel B and certainly the addition of polatuzumab, which really does, for the first time, substantially challenge the R-CHOP standard of care. So we have the POLA-R-CHIP program, and I'm going to talk about that. That's the POLARIX trial. We have bortezomib, both in green as positive studies. The red studies here are all negative, and blue are studies that are ongoing and important. So I've parenthetically mentioned polatuzumab a couple of times this evening with you, and the results of the attempt to incorporate polatuzumab vedotin, this CD79B targeting antibody-drug conjugate, reported in the POLARIX trial, which I was proud to be a participant. Now, POLA, just by way of level setting with you guys, is indeed an antibody-drug conjugate. It binds to CD79B, which is ubiquitously expressed on the surface of malignant B cells. Attached to this antibody is MMAE, monomerstatin E. This is an antitubulin agent, so it binds, it's internalized by the cell, releases MMAE intracellularly, leading to microtubule disruption and subsequent apoptosis. And we had single-arm phase 2 data to show that incorporating polatuzumab into a CHP, not CHOP, because POLA and vincristine are quite similar in terms of toxicities, but substituting POLA for vincristine seemed to have been safe and effective in newly diagnosed large cell lymphoma. So on the basis of that, we conducted a globally conducted double-blinded randomized trial for patients with newly diagnosed large cell lymphoma over the age of 18, IPI of 2 or greater, and randomized them to receive our CHP and either POLA and a vinca sub placebo or vinca and a POLA placebo. Everybody got 6 cycles of chemo. Everybody again got 2 extra cycles of rituximab to satisfy European regulatory concerns. And what did we see? So the study was powered to detect a primary endpoint of progression-free survival and the secondary safety endpoints, as you see here. We did a good job randomizing patients. This is over 800 patients that were treated on this trial around the world. And the arms were very well balanced, I would say, for all of the relevant clinical factors, including stage, IPI, cell of origin, expression of BIC or BCL2. You'll note the bottom line here, double or triple hit, these patients who have rearrangement of MYC with either BCL2 or BCL6. This is an older nomenclature, but even so, there were very few patients like that in this study, limiting our ability to draw conclusions for that disease state from this trial. But what did we learn from POLARIX? We see that this was the first prospectively conducted positive randomized trial in the R-CHOP era. And it met its primary endpoint of improvement in progression-free survival for the polar R-CHP patients compared to R-CHOP alone. Hazard ratio 0.73, a 27% risk reduction, an absolute 24-month PFS benefit of 6.5% compared to R-CHOP alone. So you'd say it's a modest clinical benefit, but real and measurable, and just as we powered it. What about overall response? Again, overall response was very high in both groups, as you would expect. Disease-free survival curves parallel those of the progression-free survival curves, which is always reassuring to see in such studies. Importantly, we do not yet see an overall survival benefit for the polar-treated patients compared to R-CHOP alone. The median follow-up is still relatively early. We have certainly improved treatments for patients with relapsed large cell lymphoma. Whether there will ever be a survival benefit detected or not remains a very open question. But at very least, we see that we can improve progression-free survival in these patients. So then you have to ask the question, well, if you're only improving progression-free survival, do you really need to give it to everybody? And this is where people like to perseverate over subgroup analyses. And remember, please, I always say when I show this slide that you have to take it with a grain of salt. These are all post hoc, unplanned analyses. These were not powered studies. We spent no alpha on this work. This is all just trying to get a feel of if there might be signal here. What do we see? There's a couple of things that are worth talking about here. The first is the very bottom double triple hit lymphoma. I already said there were too few patients to draw any meaningful conclusions here. Certainly you couldn't look at the results of POLARIX and say polar R-CHP is the new standard of care for patients with high-grade lymphoma. We can draw no meaningful conclusions, yay or nay. The two other categories here, well, I'll say three. The fourth from the top, you'll see IPI score. In IPI 2, your little box whiskers is centered right around 1. IPI 3 to 5 skewed increasingly towards polar R-CHP. And this is a theme that we often see in trials in aggressive lymphomas, which is that the higher the risk of the disease, the easier it is to detect an incremental benefit. It's a common lesson in this space. It's impressive that we were able to see a benefit at all when we included the overall patient population of 2 to 5. Many trials are written only allowing IPI 3 to 5 for this very phenomenon. So that's noteworthy in my opinion. The one below that, bulky disease, absent or present, you see that the absence of bulk strongly favored polar R-CHP, whereas bulky patients did not seem to derive as much benefit. That's biologically plausible to me. We know that antibody-drug conjugates in many contexts may be less efficacious in patients with bulky disease due to difficulty in delivering that chunky antibody-drug conjugate into the center of the bulk, site of bulk. So that's credible. The third from the bottom is the one that causes the most strife right now, and that's the cell of origin work. And you'll see that in this unplanned, post-hoc, unpowered analysis that the germinal center patients didn't seem to derive much benefit. The activated B cell patients derived outsized benefit. Now, what do you do with this? Do you look at this and say, well, I'm only going to offer this to ABC patients? Do you say, this is post-hoc and I treat according to the protocol, and if they're eligible, they're eligible? I personally espouse the latter principle because of its post-hoc nature. When you look at the other studies that have been conducted looking at polatuzumab and large cell lymphoma, it has not been a consistent and clear message that there's differential activity by cell of origin. So I think that this remains an area of interest and of uncertainty, and certainly will be looked at in future studies. So I've said that there's a progression-free survival benefit, no overall survival benefit. So what do you get for that? And certainly there are times where we have a PFS benefit without OS benefit. And we say, is it worth the trade-off? You have a drug that's much more toxic, for instance, but gives you a little bit of PFS benefit. That's a judgment call. Here, I would say that the toxicity profile of polar R-CHP compared to R-CHOP is really very similar in terms of overall adverse events, in terms of frequency of high-grade adverse events, in terms of drug discontinuation, or dropping the dose of the study drug, pola or vinca, or overall dose reductions of any study drug. The two arms are really identical, affirming that pola R-CHP is really no incremental toxicity cost over R-CHOP alone. So our conclusions were that the POLARIX regimen of polar R-CHP does indeed significantly prolonged PFS compared to R-CHOP alone, and it does so with a toxicity profile similar to that of R-CHOP standard of care, supporting the use of pola-R-CHP in the initial treatment of patients with large cell lymphoma. This has now gone on to receive FDA approval in the United States for this indication. Admittedly, this is not going to be a global solution, and this is a global audience this evening. So every health system is going to have to decide how it's going to spend its shekels. And there's no doubt that cost-benefit analyses, looking at the impact of polatuzumab in the first line, need to be performed within the context of each health system. We look forward to reporting our cost-benefit analysis, looking at the POLARIX regimen, so stay tuned for future manuscripts and congresses. But that work is done in the context of U.S. health payers and the U.S. health payer mix. Every health system is going to have to make these choices in terms of the cost-benefit analysis in that specific context. So what does the future possibly hold? How are we going to move beyond even Remodel B or POLARIX? So the first thing I'll say there is to look back to the past and to call one of those prior negative studies, that being the Phoenix trial, which was a randomized trial of R-CHOP plus or minus ibrutinib. And this was a randomized, double-blinded study looking at patients with activated B-cell large cell lymphoma, the subtype that should be influenced by ibrutinib. And this study, as I've already said, was a negative study. No improvement in its primary endpoint of event-free survival, either by intention to treat or when you actually peel out the specific ABC patients. However, when you look further and you look by age, we see that younger patients treated with R-CHOP plus ibrutinib actually had significantly improved outcomes compared to older patients who actually had slightly inferior outcomes with ibrutinib. When you break that down into EFS and OS, if you look at the younger patients treated on the Phoenix trial, there actually was an improvement, not just in EFS, but in overall survival for the ibrutinib, including patients under the age of 60. This was unplanned post-hoc analysis. This is not and should not be the standard of care, but it's highly provocative. And this is a good example of what you do with these post-hoc analysis. I mean, wow, maybe we have a real signal here in younger patients, including BTKs. You say, well, why would that be? It looks to me like a lot of that, perhaps not all of it, but a lot of that is driven by tolerability. And we know that adding a BTK inhibitor to R-CHOP does add toxicity, but that seems to be outsized phenomenon in older patients, more myelosuppression, more infections, more drug disruption, more treatment discontinuation, more dose reduction. So if you're delivering less treatment, even though you have a BTK in there, you're not going to be having as positive an impact. Whereas in younger patients who tolerate the combination more consistently, you can have more reliable drug delivery and thus reap the putative benefits. So again, when you look by age, the outcomes really are quite striking. And the R-CHOP plus ibrutinib in younger patients really does look excellent. What do you do with that? Well, we build the next study. And here what we did is we built Escalade, which is a trial that I'm proud to be helping to lead, which is a globally conducting trial, taking patients with newly diagnosed large cell lymphoma, IPI 2 or greater, limiting it by age to younger patients. We started at 65, we've gone up to 70 based on some additional analyses, but really excluding those older patients that seemed to be most sensitive to the toxicities of BTK incorporation. Everybody gets a cycle of R-CHOP while we figure out their cell of origin. If they're proven to be activated B cell by molecular profiling, they're then randomized to get a acalabrutinib or a placebo with the primary endpoint of progression-free survival. The study is ongoing, making good progress, and we hope to finish it hopefully within the next year and then allow the data to mature. Other opportunities include the incorporation of venetoclax, the BCL2 inhibitor, that's made waves both in the treatment of acute myelogenous leukemia and MDS, but also a useful drug in the treatment of certain forms of lymphoma, including CLL. My participation here was helping to participate in the trial called Cavalli, which was a single-arm trial incorporating venetoclax into an R-CHOP program in patients with newly diagnosed large cell lymphoma. What we learned from Cavalli was that patients who had BCL2 positive disease, either by immunohistochemistry or by cytogenetics, but even IHC alone, it looks like the outcomes with patients treated with venetoclax were actually significantly better than they would have been with an age-matched cohort control from a prior large clinical trial called Goya. Whereas those who had disease that did not express BCL2 seemed to derive no benefit from the incorporation of venetoclax. Why don't we do this then? Because again, we have toxicity challenges when you add drugs on top of R-CHOP. Here we saw there was significant myelosuppression with some treatment-related fatalities, unfortunately, but certainly difficulty delivering full dose of drug with this venetoclax program. So we're trying to learn from our experiences, and the next wave of this is incorporating the Polarix backbone as opposed to the R-CHOP backbone, and using a more attenuated format of venetoclax, trying to not overdo it here, taking patients again with newly diagnosed large cell lymphoma, immunohistochemistry positive BCL2, IPI2+, to see what we can achieve as we continue to try to iterate here and figure out how best to deliver venetoclax for BCL2 positive disease. Other approaches that are very interesting and promising include incorporating immunotherapies, such as CAR T-cell therapy. And the ZUMA-12 study was reported at not this past ASH, but 2 ASHs ago, looking at using axicabtagene ciloleucel or axi-cel as consolidative therapy. So patients who had high-risk large cell lymphoma, they'd go and they'd be induced according to standard treatment. And then if they were subsequently eligible, either because they had a positive interim PET scan after 2 cycles of treatment, or perhaps if they were MRD positive at the end, would go on to receive consolidative CAR T-cell therapy. And when you look at the patients in the ZUMA-12 program, despite being high risk because of the suboptimal speed of response, we were able to get 40 patients through and able to get them axi-cel. And those patients at reporting time were doing phenomenally well in terms of responding to the CAR T therapy and even sustaining that response, as shown here in terms of duration of response and progression-free survival. Overall survival still being excellent at this early follow-up time as well. Challenges with axi-cel, of course, is that it's axi-cel, and CAR T-cell therapy in general, axicabtagene ciloleucel particularly, does confer significant risk of toxicity, including cytokine release syndrome, as well as neurological adverse events, or so-called ICANS. And the rates of CRS and ICANS in ZUMA-12 were substantial, highlighting the challenges with routinely applying CAR T-cell therapy, even for patients with relatively well-debulked large cell lymphoma. Other approaches that are being pursued, there's a treatment program combining a CD19 naked antibody called tafasitamab in combination with lenalidomide, the immunomodulatory drug. And TAFA plus len, or Tafa-len, was studied and subsequently approved in relapsed large cell lymphoma, demonstrating high activity and durability in a subset of lower risk patients with relapsed large cell lymphoma. But because it does have non-cross-resistant toxicity with R-CHOP, it's interesting to explore the consideration of whether you could incorporate this Tafa-len doublet into first-line therapy. And this work has now been kicked off. We've seen that you can administer Tafa plus R-CHOP, or even Tafa-len plus R-CHOP, as was done in this sort of pilot randomized trial, demonstrating that Tafa-len R-CHOP is actually not much more toxic, interestingly, than Tafa plus R-CHOP, suggesting that it may indeed be feasible to try Tafa-len R-CHOP in a randomized trial. We were able to, in that earlier study, to maintain dose density, which is always encouraging. So because it was shown to be feasible, there is now an ongoing study, again, taking patients with newly diagnosed large cell lymphoma, here IPI 3 or greater, and randomizing them to either R-CHOP plus Tafa-len or R-CHOP plus placebos. Lastly, I do want to highlight the potential of bispecific antibodies in large cell lymphoma. Bispecific antibodies, for those that may not be fully aware, are constructed antibodies that have not just one binding site against whatever the malignant cell is, in this case, the malignant B cell targeting CD20, but have a second binding site targeting CD3, bringing over T cell, creating an immune synapse, activating and leading to cell proliferation of the T cells and T cell mediated killing of the tumor cell. And there are a number of such bispecific antibodies that are in ongoing clinical development, some of which are shown here: epcoritamab, mosunetuzumab, glofitamab being the closest to approval. Mosunetuzumab, in fact, has achieved its FDA approval in the treatment of multiple relapse follicular lymphoma, and we are eagerly awaiting consideration of FDA approval this calendar year for both epcoritamab and glofitamab in the treatment of diffuse large B-cell lymphoma for patients with multiple relapsed disease. But because these drugs have such good activity and tolerability that is favorable in comparison to that of CAR T-cell therapy, there are a number of ongoing efforts to incorporate one of these bispecific antibodies into treatment paradigms for patients with newly diagnosed large cell lymphoma, both fit or unfit patients. And you can see here, if you can think of a subset of patients with newly diagnosed large cell lymphoma, somebody has already writing or written or opened a study incorporating a bispecific antibody to attempt to improve outcomes in that subset of patients. So with all that as a very long, but hopefully abbreviated tour through the data underlying treatment of patients with large cell lymphoma, let's go back to our patient, again, 46. Workup showed stage 4 disease, bilateral renal mass and liver mass. Highly avid. We did a biopsy, showed activated B cell or non-germinal center subtype large cell lymphoma. How do we treat such a patient in the modern era? You certainly still could just give R-CHOP times 6. Remains a standard of care. You could say this is an activated B cell patient. I'm going to send the molecular signatures, but on the basis of remodel B, I'm so enthusiastic about this post-hoc analysis using the molecular signature as opposed to immunohistochemistry that I'm going to buy it and try to incorporate bortezomib. You could take the FDA-approved approach of Polarix and say this is an ABC patient. Those are the patients that derive the most benefit. This patient has an IPI score of probably 4, certainly eligible or appropriate for Polarix. You could try to put him on a clinical trial. You could try to get him R-CHOP plus or minus acalabrutinib on the Escalade study. And then you're going to be stuck in the same position we all are right now, talking about central nervous system prophylaxis. His CNS IPI score is very high. He has a high IPI. He has renal involvement. Everyone would be worried about this patient being at risk for CNS relapse. And we would have a discussion highlighting our ignorance, but talking about the pros and the cons of considering high-dose methotrexate as an attempt at prophylaxis. I hopefully made it under the allotted time, allowing us some time for discussion, which was frankly the most interesting part of any of these presentations, certainly the most fun for me. But I'd like to thank my colleagues at the Rutgers Cancer Institute, New Jersey, and RWJBarnabas Health. I have the honor of working alongside an amazing and dedicated group of physicians. We're the sole designated NCI cancer center in the state of New Jersey and responsible for carrying over a flock of more than 3 million patients. And it's a pleasure and an honor to be a leader and a partner of this program. So thank you so much for the invitation to share my thoughts with you this evening. And I really look forward to discussion with you guys. Thanks so much. I'm going to stop sharing my screen.
Thank you once again, Doctor, for that wonderful keynote. It was truly educational, and the presentation, it was really informative and quite eye-opening. So with that, I'll hand over the mic to our moderator, Madhuri.
Thank you so much, Shivika, and thank you, Doctor, for this wonderful presentation today. Welcome, everyone, to MedNews Week, discussion with global leaders, where we discuss and talk about the situation and have some questions for our amazing speaker. Today, we have with us Dr. Matasar, who's talking about the updates in diffuse large B-cell lymphoma. He is the chief in the division of the blood disorders at Rutgers and RWJBarnabas Health. He's an internationally recognized leader, physician, and researcher in hematology and oncology. He has led over 30 clinical trials that has gotten FDA drug approvals and is the recipient of multiple national awards and also leadership positions. He's a passionate educator and mentor in hematology and has also won an award by the MSKCC for the hematology attending teaching. He has authored multiple renowned papers and publications, and we're truly excited to hear from him today. For the first question, I will be passing the mic to Dr. Yan.
Thank you so much. Thank you so much, Dr. Matasar, for an amazing presentation. Truly a pleasure to learn from you. And thank you for highlighting the global landscape of DLBCL therapeutics. My question is gearing more towards the present/future. Cell therapies have made a profound difference in the DLBCL landscape as a whole. What are your thoughts on the future of cell therapies, particularly off-the-shelf therapies that are currently in preclinical studies, NK cells, and where do you feel they would possibly fit in the future landscape? Do you feel, if successful, they could supplant recently approved, FDA-approved CAR T-cell therapies? Thank you.
Thanks, Dr. Leifman. It's a really challenging question. So, and again, I want to be attentive to the fact that our audience tonight is a global one. So one has to take into account access questions as fundamental to the subject. Even in a country like the United States, where that is fast and loose with our healthcare resources, one might think, well, there must be such wonderful access to CAR T-cell therapy. The healthcare system has almost no constraints on how much we spend on our patients, which is shocking, but true. And even in the United States, there was very nice work by a mentee of Rutgers that was presented this past year, that even when you look most narrowly at the patients that we know CAR T-cell therapy is the preferred curative option, multiple relapsed large cell lymphoma, and you say, of the patients in the country who have this diagnosis, who look like they should be eligible, what percentage of patients actually go on to receive CAR T-cell therapy or even referred for it? And it's a shockingly low number, right? The vast majority of patients who would benefit, at least putatively, from CAR T-cell therapy for the treatment of relapsed aggressive B-cell lymphomas in America is really woefully inadequate. We have to learn our lesson here, right? So CAR T-cell therapy is life-changing. It's incredibly innovative and incredibly powerful therapy. And in its current iterations, it does not have the ability to change the world. It's an amazing proof of principle and an amazingly powerful therapy for those that can access it. But what it tells us is that T-cell engagement, by hook or by crook, is a path forward in this disease. What's the best way to do that? I don't know. Do I think that allogeneic CARs, allo CAR T or allo CAR NK are the future? Not based on what I've seen so far. They have activity. And when it comes to allo CAR NK, they're very well tolerated, but they lack that special something that auto CAR T has, which is durability. And at least what we've seen so far, we haven't been able to recapitulate the durability, the cure, in other words, with allogeneic products. Is it possible that bispecific antibodies, as a different strategy to engage T cells, will be a better path forward? It's certainly possible. We know that access to them will be easier. They can be administered in routine oncology clinics. They can be saved and stored in a stable fashion. Oncologists globally are much more comfortable administering antibodies and administering cellular therapies. The regulatory oversight and apparatus that is needed to administer the treatments is far more streamlined. And in America, we're already seeing some community uptake in the use of mosunetuzumab in patients with follicular lymphoma. So we're starting to see that proof of principle. We also see it in myeloma by and by, which has a medicine called teclistamab, which is, again, a bispecific antibody in the treatment of hematologic malignancy, in that case, myeloma. So The problem, of course, with bispecifics right now in large cell lymphoma is that they don't have the same evidence of cure that we have with CAR T cell therapy. May they offer it? We just don't know yet. Possible. More likely in my mind is it's going to require combination approaches. And you could imagine that a bispecific antibody with some sort of immunoadjuvant therapy, whether it's other antibodies, whether it's immunomodulatory drugs, whether it's cytotoxic therapies, whatever we're going to pair them with, can we get bispecific plus X or plus XY to be equal to CAR T and at the same time be a more globally relevant therapeutic approach? I hope so.
Thank you so much. Really appreciate it.
Thank you so much, Doctor, for that wonderful answer. And it is really great to hear more about this. For the next question, I'll be passing the mic to Shivika.
So once again, thank you, Doctor, for such an amazing keynote. So my question to you is, like, in aspect of precision medicine and AI, what are the latest improvements in the treatment approaches that are available for like the relapse of DLBCL?
So precision medicine and AI, I'm going to tackle those separately because they're both interesting. It's a good question. Precision medicine wise, I guess I would take us back to those first slides I showed with in terms of the different classification schemas. And you could apply precision in terms of the diagnostic evaluation. And certainly I continue to be optimistic that some future state we will find us where, you know, the different substrata of diffuse large B-cell lymphoma are treated differently. We may already be there with the data from Remodel B and molecular signature activated B-cell patients benefiting from bortezomib-based treatment is an example of such possibilities. Certainly that's not the only way that we can be applying precision medicine. Another is this concept of minimal residual disease and looking at depth of MRD response either to determine prognosis or even more provocatively to guide therapy. And there are trials that are being developed now that look at the rate of decline of detectable cell-free DNA in the blood, for instance, to decide whether or not patients are performing as expected or whether they may benefit from therapeutic intensification. Or patients who are MRD positive at the end of treatment, maybe those patients may benefit from some sort of consolidative approach, whether CAR T or bispecifics or some other approach. You could also use the same approach as I suggested, perhaps in the CSF to determine risk of central nervous system relapse as a different way to think about using ctDNA or cfDNA precision approaches to attempt to guide therapeutic decision making. AI, that's a really tough one, right? So you could imagine AI algorithms being used to help enhance diagnostic clarity, where you get some panel, not of 5 or 10 antibodies, but of 100 antibodies, and have the AI try to learn from big data which of a various bunch of treatments may be better. So imagine a world where we have Polarix, Remodel B, Escalade. Now we have 3 different programs, all of which might be good for an activated B-cell patient. Maybe there are subtleties to those patient subsets within ABC that may point us towards preferring one or the other or yet the other. And you can imagine a learning AI that is able to help an oncologist pick among reasonable choices based on a large data set to develop some sort of patient-specific discriminants. Not there yet, but you could imagine getting there.
Thank you, Doctor, for that wonderful answer. And it's truly enlightening to know more on these certain risk-based these therapies as well for this. So thank you so much for that. For the next question, I will be passing the mic to Muskan.
First of all, thank you so much, Dr. Matasar, for that wonderful, insightful presentation. I learned a lot, and I do have a question I want to ask you. So Are there, so certain therapies may be rendered ineffective due to various genetic or biological biomarkers. So have you noted any patients who have displayed resistance to R-CHOP or any other different types of therapeutic regimens that you may use for DLBLC? And if so, what are the alternate therapies that you can use? And also, have you been able or have you identified any genetic markers that may play a role in this resistance? Thank you so much.
We remain so ignorant about underlying mechanisms of resistance, right? We know that the vast majority of patients with aggressive B-cell lymphoma will have their disease respond to anthracycline-based chemotherapy. We have these very crude prognostic models like the IPI or the revised IPI that give us a feeling for the riskiness of a patient in terms of the likelihood of their disease failing to go into remission or to relapse subsequent to treatment with R-CHOP chemotherapy. But do we really understand at the cellular but molecular level the underlying mechanisms? Not nearly as well as we should. Certainly an enhanced understanding of mechanisms of resistance is going to be important if we're going to make greater leaps forward in the field. It's been challenging. There was a lot of optimism back, a decade or more ago, saying, well, let's take patient-specific specimens and let's do in vitro assays and put different chemo cocktails in there and see which ones kill it the best, or create animal xenografts and try to test different programs in an animal. And all these efforts so far have been frustratingly unsuccessful. There's a lot of interest nonetheless ongoing in terms of trying to develop some sort of in vitro platform upon which to base our clinical decision making. It remains a hope. There's very fascinating being work done at Rutgers by one of my fellow investigators to attempt such a maneuver for patients who are being treated with CAR T-cell therapy, and to try to create an in vitro immune synapse model where you could take patient-specific specimens or T cells or tissue specimens, and then try to create aliquots of various CAR T therapies. You could say lysocell, axicell, T-cell, and you can quantify the quality of the immune synapse for an individual patient to determine which of the 3 FDA-approved CD19 CAR T-cell therapies might be best for that one patient. So there's a lot of interesting work being done to try to get at patient-specific understandings of therapeutic decision-making informed by an understanding of resistance. We're just not there yet.
Thank you so much, Doctor. I'm really excited to see what avenues go on and what avenues open in the future with regards to this. Your answer was really insightful. Thank you so much.
Thank you so much, Doctor, for that wonderful answer. It is really interesting to hear about as well, and I'm really hoping to see more for this. For the next question, I will be asking you, and it's in a way, kind of a follow-up of something that you've just spoken about in one of the questions. I've recently read a lot of studies for the past 2 years talking about risk-adapted therapy based on classifications for diffuse large B-cell lymphoma. And how can this actually improve the outcomes in patients who have relapsed refractory disease itself?
So a lot of what I've spoken about this evening in terms of risk adaptation is in reference to patients with newly diagnosed large cell lymphoma. We talked about the IPI and how a lot of the trials that I've talked about really restrict the investigation to higher risk patients. That's because patients with lower risk disease are lower risk. So it's harder to detect an improvement in the standard of care when the standard of care is pretty good. When it comes to patients with relapsed or refractory large cell lymphoma, it is unusual to have patients have low risk disease because the very fact that it's back is not a good thing. So everybody with relapsed refractory large cell lymphoma, by definition, has some higher risk. That being said, not all relapsed refractory large cell lymphoma is created equally. And one example of that is to look at patients who have later relapsing disease. We know that patients with primary refractory disease or early relapsing disease are the highest of high risk. And conversely, patients who relapse after more than 2 years are lower risk yet. Not to say that's a good disease to have, it's not, don't misunderstand, but less high risk is maybe a better way to say it. When you look at that less high risk patient population, you can actually approach those patients clinically quite differently than patients with primary early relapsing disease, where you're really rushing either to get them access to CAR T or to come in quick with whatever you're going to do to try to fix them. Patients with later relapsing disease often have a more indolent natural history. They're often less sick from their disease. And when you look at outcomes in those patients with novel therapies, whether it's the Tafa-Len program that I spoke of briefly, or polatuzumab-based treatment with the polatuzumab, bendamustine, and rituximab program, if you look at patients with late relapsing disease treated with either of these approaches, their outcomes are actually quite excellent, at least compared to what we would have expected historically for patients with relapsed large cell lymphoma, with median overall survival measured in years and years. So an understanding that not all patients are highest risk, and an understanding that you can approach later relapsing patients as a group with different biology and a different risk profile that may benefit from less intensified approaches without compromising outcomes, I think is important.
Thank you, Doctor, for that wonderful answer. It's great to actually know about it because you'd spoken so much on it. And this is really a truly exciting time as well. Thank you so much for that answer. For the next question, I'll be passing the mic to Rita.
Good evening, Dr. Matasar, and thank you so much for your incredible keynote. In the recent years, there has been a shift of focus and progress has been made in cancer vaccines. Do you foresee a vaccine as a promising therapy for the future of diffuse large B-cell lymphoma?
It's a very timely question. So there is still ongoing work in so-called cancer vaccine approaches in the treatment of patients with relapsed refractory large cell lymphoma at the very least. And there's a drug that is in ongoing development that I serve as the global lead PI for, called maveropepimut, which I know just rolls off the tongue. But this is a form of a cancer vaccine therapy here targeting an antigen called survivin, which is widely, although not ubiquitously, expressed on diffuse large B-cell lymphoma. And maveropepimut S is a way of delivering a survivin vaccine packaged in some lipophilic particles that has been demonstrated in earlier studies to have quite nice activity, particularly when given alongside immunoadjuvants such as pembrolizumab and low-dose oral cyclophosphamide, both in an attempt to immunomodulate. And for patients whose disease expresses PD-L1, the combo of maveropepimut S and pembro and low-dose oral Cytoxan actually had a very attractive activity profile combined with very good tolerability. And there's work ongoing to attempt to more fully characterize the activity of MAV and pembro with or without oral Cytoxan to try to see if there's an opportunity to move the survivin vaccine approach forward.
Thank you so much, Doctor. And that's actually really interesting in terms of the whole vaccine therapy for this. And thank you for your really great answer. For the next question, I'll be passing the mic to Harshu.
Oh, yes. Thank you, Doctor, for this very insightful session. So my question is, how important is the multidisciplinary collaboration in the diagnosis and treatment of diffuse large B-cell lymphoma, and how can we encourage more collaboration between different medical specialties and research fields?
It's a really good question. So the how important part is easy, super duper important, right? I tell my patients that I could be the best doctor in the universe, and Lord knows I'm not. But even if I were, if I didn't have the right people around me to help me achieve an accurate and precise diagnosis, to understand the extent of staging, to understand cardiac and renal and hepatic function, everything that we need to do to conduct our care of our patients, it's all critically important, and no doctor is an island. I really like to focus, when I talk about multi-D care, on the relationship between the oncologist and the pathologist. Because again, I could be Maimonides reborn, like the greatest physician in Jewish lore. And if I'm given the wrong diagnosis, I'm going to do the wrong thing. So much of this comes down to diagnostic precision and accuracy. We actually looked, when I was working at my former institution, at the question of how often, when a community pathologist in the United States makes a diagnosis of lymphoma X, and we reviewed it to give a second opinion, how often did we change the diagnosis in a way that was clinically relevant? Meaning, if it had been diagnosis X, you'd get treatment X, but because it's diagnosis Y, you get treatment Y. And it turned out that even here in the US, with all of our access to expensive diagnostic stains and tools, that fully 1 in 5 patients at a second opinion pathology review had a major diagnostic revision. The importance of pathology expertise, of hematopathology expertise, is really impossible to overstate. And when I talk about global care and global access to hematology leaders around the world, I'm often focusing the conversations around how do we collaborate in the not only in the care of patients, but in the diagnosis of patients, and finding ways to link pathology resources and expertise in the diagnosis of what can be rare forms of lymphoma. Large cell is common, third of patients in America. But there are more than 100 different subtypes of lymphoma, some of which pathologists may have never seen in their routine practice. So how do we align resources and expertise with need, not just locally, but globally? This is a tremendous challenge, and one that I hope that the emerging global leaders in this group and on this call tonight are going to be able to help tackle, either with me or after my race is run.
Thank you, Doctor. And that was definitely an amazing point of view. And we're definitely hoping to tackle the situation with you probably in the next future years as well. Thank you so much for that. Now we're coming to our last question for today. Over to you, Jenna.
My last question, for our more junior attendees just getting started into research in medicine, what inspired you to pursue the field of oncology? And how did this choice impact your life? Has it been everything that you initially anticipated?
So my career path has been a wandering one, I'll be honest. When I went to college, I was fully convinced I was going to be a philosophy major. And I was for my first 3 years of college. And it wasn't until I had a crisis of conscience and said, oh, what does it mean to be a philosopher? Am I going to have an impact on the world around me that's enough to feel like I lived a good life? And I asked myself that question, and the answer was that I think it would have come up short. So then I had to go back and say, well, how can I make a bigger difference? And I was still interested in philosophy and in ethics. So I said, oh, I'll become a medical ethicist. That's at least a way to be practical about this, and maybe a little bit more impactful yet. So I went to medical school not to become an oncologist, but to become a medical ethicist. And it wasn't until I was in medical school that I fell in love with taking care of patients. And it's a little bit selfish at some level, but it was so transfixing and rewarding. It was like nothing I'd ever experienced. The ability to stand with somebody at a time of sickness and fear, and to be willing to roll up my sleeves physically and intellectually to try to figure out how to help them, was deeply gratifying and I'd say addictive, I guess. But I certainly got bit by the bug. That pushed me into internal medicine, and then within medicine, oncology drew me because the stakes were always so high. And I had the sense that the patients who were coming in with a diagnosis of cancer were the most scared and often most sick. And thus, if I could be a good doctor, maybe I'd actually make a bigger difference. And this has always been my guiding principle: is how do I make the world a better place? How do I make a difference? I just don't want to waste my time here. We all only got so much of it, right? So how can I make a difference at work, at home, in my community? That's what wakes me up in the morning. So that would be my advice to everybody there: is try to figure out what motivates you, what drives you, how can you make a difference, what skills do you have to offer, and what challenges are you able to take on to do the work of helping heal this world.
Thank you so much, Doctor. And I truly hope that we're also able to make a difference in any kind of way, and we're able to find our motivation to definitely move forward and find what is kind of our path and also as well. Thank you for this wonderful, wonderful presentation for today.
Thank you. It's been a joy to speak with you guys this evening, and thank you for what you do in helping raise awareness and educate the world, and to help create the next generation of leaders.
Thank you so much, Doctor. Thank you, everyone who is here for today as well, for this wonderful conference. And please look forward to our next one as well. Thank you, guys.
Can we cut the recording? 1 second.